Community acquired pneumonia is something which is very common in our wards. I think in every ER we see multiple patients who present to us with LRTI. And when do we say that this patient has CAP or community acquired pneumonia? It is if a patient has acquired a lower respiratory tract infection from a pathogen which is found commonly in the community, or if the patient has acquired this infection within 48 hours of hospital admission. After 48 hours, it becomes hospital acquired pneumonia. So, some of these common organisms include strep pneumoniae, which actually causes two-thirds of cases of all community-acquired pneumonia. H. influenzae is another common cause. Then, according to some risk factors, Klebsiella, Staph aureus, and Moraxella, Chlamydia, Legionella, and to some extent Mycoplasma also cause community-acquired pneumonia. It's very important to know about these organisms because the empiric therapy is based upon the prevalence rate of these organisms. So viruses can also cause CAP, and actually they make up 20 to 30% cases of all community-acquired pneumonia, including SARS-CoV-2 or COVID-19, which has wreaked havoc on us in the last few years. MERS can also cause it, influenza, parainfluenza, respiratory syncytial virus, adenovirus. It is, however, quite difficult to differentiate whether a patient has viral pneumonia or bacterial pneumonia. There may be some clues. We can use procalcitonin or CRP, but as procal is a late riser, they're both not very specific for it. And sometimes a patient might have viral infection, but they may also develop a superimposed bacterial infection. So usually the treatment is ongoing for both unless some uncommon causes of CAP include zoonotic organisms like Coxiella bruneti, which causes Q fever, Francisella tularensis, which causes tularemia, and certain fungal organisms like Blastomycosis, Coccidioides, or Histoplasmosis. And very, very rarely, hantavirus can also cause a pulmonary syndrome. So, clinical features of CAP include fever, cough, which may be dry, it may be productive, there may be signs of pleurisy or chest discomfort, and there might be hemoptysis, but only in cases of necrotizing pneumonia or in cases of mycobacterial infection. Some patients, especially the elderly patient, they might not present with respiratory symptoms at all. They actually can present just with fatigue, lethargy, anorexia, myalgias, or just increased rate of falls. There may be some altered level of consciousness in some patients, especially the elderly population, which may range from small behavioral changes to acute psychosis or delirium. There may be just GI symptoms as well. So, on examination, the patient may be hypothermic, they may be hyperthermic, they might have tachycardia, they might have tachypnea, there may be decreased oxygen saturation on room air, and the patient may also have bronchi or crackles or bronchial breathing on auscultation of the chest, and there may be symptoms of pleural effusion. The diagnosis of community acquired pneumonia is largely clinical. However, even in that case, the symptoms and the physical examination only correlate 60 to 70% of the time with the diagnosis. And it's actually better to get an imaging done and to confirm the presence of infiltrates or consolidation on a chest X-ray or sometimes even on CT, especially if you're considering mycobacterial infections. Patients who are admitted in the hospital, it's useful to get a sputum culture done, even though it has a yield of only less than 50%. The reason being that we can see patterns of resistance and to see common organisms which are involved in your region or in your wards. So, for a sputum sample to be viable, it needs to have more than 25 neutrophils and less than 10 squamous epithelial cells in the sample. Patients sometimes have difficulty expectorating, especially the elderly patient. In these patients, we can induce sputum, or a tracheal aspirate can be taken if the patient is intubated or in the ICU. Blood cultures have even lower yield in patients of CAP, mounting up to 15% only. However, in patients who have other comorbids or in patients where we're suspecting MRSA or Pseudomonas, then it's useful to get blood cultures as well. Urinary antigen tests are available for Legionella and for strep pneumoniae. These tests can be done if there is a high suspicion of Legionella according to the clinical history. And these tests are very sensitive and very specific. However, they are not generally employed unless there is a strong indication or if the case is very severe and not responding to any treatment. Serologic tests can be employed to find out atypical organisms or organisms like Coxiella bruneti, and a fourfold rise in the IgM can actually be diagnostic of these pathogens. However, these tests are not generally employed because of the time it takes and how difficult it is to interpret these tests. Nasopharyngeal PCRs are very important, especially for viral causes of CAP, and these tests can also detect other organisms, bacterial organisms like Legionella, Mycoplasma, Chlamydia, and Mycobacteria. However, the cost effectiveness is a little bit of an issue in getting these tests done. So once we have decided that this patient has community acquired pneumonia, then we need to decide where the patient needs to be treated. Do they need to be admitted in the hospital or can they be sent home on oral antibiotics? For that, there are two basic scores which can be used. The PSI score, which includes more than 20 variables, and it has different classes. So class 1 and 2 can be treated at home, but class 3 needs to be admitted in the hospital. The score is a little lengthy and difficult to remember, so CURB65 can be used instead. This score includes 5 criteria, including confusion, which is characterized by a mini-mental score of less than 7 by 10. Uremia, with a urea of more than 7 millimoles or more than 40 milligrams per deciliter. A respiratory rate of more than 30. And for B is for blood pressure, either a systolic blood pressure of less than 90 or a diastolic blood pressure of more than 60. 65 is the age, so any patient who is above 65 obviously has more morbidity associated with it. So a curve score of 0 can be sent home safely on OPD basis, and a score of 1 or 2 should be admitted in the hospital unless just the score is just age. A score of more than 3 has a very high mortality reaching up to 22%, and these patients should ideally be in a high dependency unit or should be closely observed or in an ICU setting. Other patients who require ICU admission are patients who are on inotropic support and patients who require intubation and mechanical ventilation. These scores are not the ideal way. They can just help you in your clinical judgment. However, patients who are elderly, who cannot be taken care of at home, patients who do not have an adequate oral intake, or patients who cannot maintain their oxygen saturations on room air, have an oxygen saturation of less than 92%. These patients should also be admitted. Once it's established that the patient needs to be treated at home, then we need to further classify these patients into patients who have comorbids and patients who have no comorbids. And by comorbids, I mean patients who have any chronic lung or kidney disease, diabetes, hypertension, or patients who do not have a spleen, patients who have a neutropenic sepsis for any reason, and sometimes patients who have had reason for increased resistance, for example, patients who have been hospitalized within the last 90 days or who have received any IV or oral antibiotic within the last 3 months. For patients without any comorbids, the guidelines say that we can give amoxil 1 gram TDS alone. However, we need to cover both strep pneumoniae and the atypical organisms. And as a rule, we give both amoxil plus either a macrolide or amoxil plus doxycycline. Another option is to give doxycycline alone as monotherapy or as a last resort if the patient is allergic to both amoxil or you cannot give doxy for some reason, then you can give macrolides alone. However, before starting monotherapy with macrolides, it is mandatory that the local resistance is less than 25%. So in our setup, especially with azithromycin being such a precious drug, we've overused it in COVID, and especially it's the only drug that the uh, enteric fever is now responding to, then it's best to avoid monotherapy with macrolides. OPD treatment for patients with comorbids is to either give a beta-lactam with doxycycline or to give beta-lactam with macrolides. So beta-lactams include amoxicillin clavulanate, or they can include certain cephalosporins like cefpodoxime and cefuroxime. So we can give it either with a macrolide or with doxycycline. The second option is to give a respiratory fluoroquinolone alone, and these include levofloxacin or moxifloxacin or gemfloxacin. The duration of therapy is usually limited to 5 days. However, it depends on the clinical condition of the patient and it may be extended up to 7 days. For treatment of hospitalized patients of CAP, we have two major concerns. One is to cover for Pseudomonas aeruginosa and to give double coverage wherever it's appropriate. And second is to look for risk factors for antibiotic resistance. These include any recent hospitalization or any recent use of antibiotic use, either IV or oral, within the last 90 days, and also local data of resistance and the resistant patterns are also important. So based on this, we divide patient into different categories. So any patient who has a non-severe CAP requiring hospital admission but has no risk factors for resistance, then in this case we give IV beta-lactams, which include ampicillin, sulbactam, ceftriaxone, sertraline, and cefotaxime. Another option is to give monotherapy fluoroquinolones like levofloxacin, moxifloxacin, or gemfloxacin. In patients with severe CAP with no risk factors for antibiotic resistance, the treatment is pretty much the same. We can give combination of beta-lactam plus a macrolide, or this time we can give beta-lactam with a fluoroquinolone. The difference is that this time we cannot give monotherapy of fluoroquinolones. Instead, it's given in combination with beta-lactams. So, in patients who have risk factors, either their severe infection or non-severe infection, we need to cover for MRSA and we need to cover for Pseudomonas as well. For MRSA, there are two options: either to give linezolid or to give vancomycin. Linezolid has better lung penetration, and the oral and another thing is that the oral and IV do not have a lot of difference between them, so we can give either of them. For Pseudomonas aeruginosa, we have options of piperacillin, tazobactam, meropenem, imipenem, aztreonam, and cefepime. In critically ill patients who are also at risk for antimicrobial resistance, in these patients we give two anti-pseudomonals. So one is chosen from the group as above, that is drugs that cover both anti-pseudomonal plus anti-pneumococcal. So we can choose either one of these drugs. Plus, we give an anti-pseudomonal fluoroquinolone, which includes either levofloxacin or ciprofloxacin. Second, we can either add this anti-fluoroquinolone or we can add an aminoglycoside like amikacin or gentamicin, or in severe cases, both of them could be added to the anti-pseudomonal anti-pneumococcal. The duration of therapy again is 5 to 7 days, but it depends on patient's clinical condition. We also send cultures and we can change therapy according to that as well. If the patient has any viral isolates, then we add oseltamivir along with the antibacterial therapy, and it's best if it's given within 2 days of symptom onset, but it again depends on the clinical condition and when the viral isolate is detected. I hope you learned something new today in this brief overview. Thank you so much for listening.